So I would like to introduce to you our final speaker of the day, Jürgen Unützer. He is the chair of the Department of Psychiatry and Behavioral Sciences at the University of Washington and an internationally recognized psychiatrist and health services researcher. One aspect of healthcare that's frequently overlooked is the impact of behavioral health has on health outcomes, costs, and productivity. The 2016 Integrated Benefit Institute Forum reported that mental health conditions are costing employers more than $80 billion in medical expenses and productivity losses per year. Clearly, this is a major concern for all of us. And yet, until recently, behavioral health has largely been kept separate from the rest of medicine. Dr. Unützer has been working to address that problem. His work focuses on innovative models that integrate mental health and general medical services, which is crucial if we are ever to address behavioral health issues effectively. This promises to be an ongoing effort, and I'm looking forward to hearing from Dr. Unützer about the impact on value-based purchasing. Please join me in welcoming Dr. Unützer.
Thank you very much for the nice introduction and for listening to me while you finish your lunch. I am a psychiatrist. I'm a physician, a psychiatrist. I chair the psychiatry department at the University of Washington. And I've been doing work in this area for some 25 years. And I would say 25 years ago, I would have never been in front of a crowd like this. So mental health is a thing where I think the time has come for us to think about it now. And I'm really happy to talk with you about it. I'm not going to promise you that I can save you the $80 billion that you just heard about, but I think there's a lot of opportunity for us in this field to not only do better by people and save lives, but also to save some money along the way. We talk a lot now about the triple aim of healthcare reform. This is actually one example where we've demonstrated that you can, in fact, go after this triple aim. So hopefully that's what I can leave you with today. I'm going to start with letting you read this. This is something that came out of the governor's office and the healthcare authority about a year and a half ago. And I'll let you just look at it. I think I got it right. I'm going to give you some sources if you want to look it up. So this is kind of a novel concept. Why should we integrate purchasing and delivery of behavioral and medical services? And so let me talk a little bit about why. All right. There is a couple colleagues who are in a very beautiful office building just down the street in a huge institute at the UW called the Institute for Health Metrics and Evaluation. This is a program that got started with funding from the Gates Foundation and a lot of money about 10 years ago, and they go out and measure the burden of all health conditions on health, on mortality, on quality of life, and one of the things that they have published in major medical journals over the last couple of years is the first bullet on this slide, and that is that mental disorders cause about 25% of disability worldwide. 10% of all years lived with disability globally are attributed to just one mental disorder, and that's depression. In fact, depression causes 3 times as much disability as diabetes, 10 times as much disability as heart disease, and 40 times as much disability as cancer. Those are very, very hard data, and I'd be happy to give you the reference. And why is that? How could that possibly be? If I got cancer today, it'd be terrible, right? It might, ruin my whole life. It certainly would put me in a bad place for some time. If you look at it from a population perspective, people get heart disease in their 50s, 60s. People get cancer in their 40s, 50s, 60s, and 70s. And then you have treatment for that, and it might take a couple of years off your life. But when you're a person who struggles with a series of mental health or substance abuse problems, you often get that in your late teens and early 20s. And then it causes you a tremendous amount of disability, and you're living with the disability for the rest of your life. So on a cumulative population burden, the impact is much, much greater than many of the things that we actually spend a lot of time and energy and money on. Health behaviors, we also understand now, so not mental illness, but the way we behave around our health cause about 50% of all mortality. So healthcare only actually contributes about 10% to our longevity. So the thing that we all do, that's what we do at the University of Washington. That's what I do in my department. Actually, we overrate the impact of that. The way we behave around our health actually is the big driver. The other thing that, and you all know this, your employers, mental health and substance abuse problems are huge drivers of unemployment, of underemployment, and also involvement with the criminal justice system. So we have costs that affect us as a society all across all of our sectors. For the employers, the problems are high healthcare costs, and I'll show you some better numbers on that in a second. And then there is something called absenteeism, which is a person isn't doing well, so they're not at work. You've got to have someone else doing their job. That's really disruptive. It's not good. And there's something that's even more annoying, and that's called presenteeism. So presenteeism is I'm not doing well, and but I am at work. And everybody wishes I wasn't at work. I think you have a sense of what I'm talking about. And when you have one of those presenteeism days and you're working on an assembly line, assembling a Dreamliner, and you're making a couple of mistakes wiring some electrical harnesses, and that thing moves down the line. A couple days later, somebody discovers that, and it's a very, very expensive rework. So those are some real problems, some real costs. In the United States, we have a suicide about every 15 minutes. In the state of Washington, we have about 2 or 3 people who commit suicide every day. So by the time we all get done with this nice morning here, there'll be 2 or 3 Washingtonians that are no longer with us. This is not something that's just a sort of a thing that happens to weird people somewhere. This is something now that's a more common cause of death than motor vehicle accidents. It's a more common cause of death than homicides. You wouldn't believe that if you read the Seattle Times, because every time somebody has a homicide in this community, we have an article in the Seattle Times. And a couple of years ago, I suggested that for a year, what they might want to do is every time there's a suicide, they should write a story about that person, because the stories are just as interesting as the story of somebody who's been a victim of a homicide. But we're not comfortable yet, really, in many ways, talking about it. I would say this is a problem, and this is at the very bottom of my slide here. There is not a family that I have met that has not been touched by a mental health or a substance abuse problem in some way. This isn't something weird that happens out there to weird people. This is very much a bipartisan issue. It doesn't discriminate if you're a Republican or a Democrat. It happens to us, and it happens to the best of us. And if you are in a family, let's say an extended family, where somebody hasn't had a struggle with a mental health or substance abuse problem, somewhere along the line, I'd love to meet you. Because it's a challenge, and we're not always yet comfortable talking about it. This is some actuarial data done by Milliman Accounting a couple years ago, and what they looked at is a couple hundred million people's healthcare claims. And they looked at what happens to healthcare costs when you have a mental health or a substance abuse problem. So they looked at commercially insured, Medicare, Medicaid, and all insurers. And about 15% of people have at least one claim for a mental health or substance abuse problem in any given year. So that's probably a kind of a conservative estimate of how many people are struggling with this. But that's at least what we can get from claims diagnosis. And then they looked at healthcare costs. So this is the PMPM cost for a person without a behavioral health diagnosis. This is the same PMPM cost for a person who has one or more claims for a mental health or substance abuse problem. And you can see here it goes up dramatically. So for commercially insured patient, 276%, huge increase in costs from 340 PMPM to 941. In Medicaid, this is even bigger. 341%, Medicare is 250%, so more than a 250% increase in healthcare costs. That's where some of that $80 billion is. This is our spend. Now, the interesting thing is, from my perspective, I'm a mental health specialty provider. If you look at the cost of mental health specialty care, that's only really accounting for 3% of that total spend. So where is that extra money going? It goes into more ER care, it goes into more pharmacy, it goes into more inpatient medical, into more outpatient medical. Every single category of healthcare cost goes up when you have a poorly treated mental health or substance abuse problem. That's, I think, a huge opportunity from a financial perspective. So I'm a doctor, so I'm going to talk a little bit before I talk more about numbers, about another way of thinking about this. So we have, for many years, thought about, there is healthcare and health, and then there is mental health, whatever that is. And we have different funding mechanisms for that. We have different purchasing for services for that, and it doesn't work very well because a person is one person living, with both their mental health and their medical problems. And this is an example of this. So one of the common things we deal with is diabetes, and one of the more common mental health problems is depression. So if I'm a person who lives with diabetes, and I develop a serious depression, what we call in the business a major depression, a couple things happen to me. I'm going to be less likely to be able to quit smoking. I'm going to have a more sedentary lifestyle. I don't get nearly the amount of physical activity that I should be getting as a diabetic. I'm actually 50% less likely to be able to take my diabetic medications the way I should be. And there's a bunch of stuff that happens in my body. My insulin sensitivity goes down. My autonomic nervous system is changed. I have inflammatory markers and high cortisol level. These are all bad things for us. And that's something that happens when, as a diabetic, I develop a major depressive episode. So this is not just something that we're trying to smush together in a box. This is one person, and when that person develops a major depression, their body changes. So what happens when all those things happen? If I'm a diabetic, I'm going to start having poor symptom control. I'm going to be much more functionally impaired. I'm going to have the complications of diabetes happen to me at a much younger age if I'm a person living with depression than I would otherwise. And what does all of that do? It drives up mortality. So depressed diabetics die about 10 years younger than non-depressed diabetics. Very, very good data. Some of that data comes from research done right here in King County with a very large population of about 5,000 diabetics at Group Health Cooperative that we've tracked for many, many years. And those who are depressed have much higher mortality rates. They also have higher rates of developing dementia, something we're all worrying about as our brains get older. And it's not a unidirectional thing. It goes both ways. So think about it. Now I'm a diabetic, and all these things start happening to me. I lose my eyesight. I have what's called microvascular and macrovascular complications. I have strokes. I have heart attacks. My kidneys don't work anymore. What do you think that's going to do to my depression? Yes. Right? These things drive each other. And it's very difficult from a person who is a clinician really to try to disconnect them. I think this is the strongest argument I can make, other than the numbers that I just showed you, because you're spending all that money on healthcare for why we should be thinking about mental health and medical health in the same way. So a little bit more data. How do we do about this? This is a ranking that is put out by Mental Health America, very large advocacy group every year, and it ranks states in the availability of services for mental health and substance abuse problems. So what you can see here is the purple states here are sort of the ones that are in the bottom, 42 and down. And where are we? We are 48 out of 51. This is not the kind of place we like to see ourselves generally in healthcare rankings. I would say most other healthcare rankings were probably near the top. This is one where we're right between Louisiana, Nevada, Mississippi. That's not where we usually find ourselves, but that has been pretty consistently the case for the last couple of years. So we are not well resourced in this state to deal with mental health and substance abuse problems. Now I'm going to try to show you some epidemiologic numbers kind of in a graphic way. So if we take all the people that live in this state with a mental health or substance abuse problem, that's all of the people, how many of them are going to get mental health specialty care? 12% of all those people will see a psychiatrist in any given year. So the kind of person, somebody like me, one of my 300 colleagues, we have a very large department of psychiatry here. We have almost 300 faculty. And between all of us, we managed to see 12% of all the people who live in the state with a mental health or substance abuse problem. Now, there are other mental health providers. There's psychologists, there's licensed clinical social workers, there's chemical dependency counselors. If we take all the people who are licensed in the state to practice as a mental health specialist, they manage to see about 20% of all those living with mental health or substance abuse problem. 1 in 5. 40% of people will say if they're surveyed in any given year, they've gotten treatment for a mental health problem by a primary care provider. So that's their pediatrician if they're a kid, or their OB-GYN if they're a woman, their family physician, their internist, could be a nurse practitioner, somebody who they say is my primary care provider, 40%. So a lot more mental health treatment goes on in primary care than by those who are specialists. And this is the sad part. 60% of people say, I'm living with this mental illness. I've had no formal treatment, not even one session with anybody in the last year. So we have a huge amount of undertreated people. So what do we do about that? How do we close this gap? So we have a big shortage of mental health professionals in the state. And it's grown bigger. We have not increased the numbers much, but the population in the state has grown really quite tremendously. We have a huge workforce shortage. And so what do we do about that? That's what we do at the University of Washington. We try to train more mental health specialists. I put up here train and retain. Retain is a challenge. These are often jobs, especially the entry-level jobs, that are very poorly paid. They're very stressful. You're dealing with really difficult, challenging people and their lives. And it's a burnout. It's a huge burnout risk. So we train providers. They go and they work in a public setting, and after a couple of years, they're burned out and they leave. They find and do something else. So it's both a challenge to train enough and also to retain them. And we will train as many mental health providers as the state and others will fund us to do. It's a huge challenge. We are the only psychiatry department at the University of Washington for the 5-state WWAMI region. And that's a region that covers 27% of the landmass of the United States. And 65% of the counties in this region that we serve as a medical school for don't have a single psychiatrist, psychologist, or social worker. This is also true in our state. There are many, many counties where there aren't any mental health professionals. And we would have to train a heck of a lot more if we really tried to make a difference about this. The other thing I think we need to do is, can we train more? This is, can we work differently? I think those of us who are mental health specialists, we need to leverage ourselves a little bit more effectively. We need to find ways of using technology, of partnering with other people to try to reach more people, to help more people. And that's what I'm going to spend most of the time talking about. We can partner with primary care providers. You saw that primary care providers already do a lot of mental health care. So if we partner with them in a smart way, we can make a huge difference. We can partner, and we do that actually here in Seattle, school-based health centers. So where are the kids? The kids are in school. And if we wait for them to be so mentally ill that they're dropped out of school and they're in juvenile detention or they're in some specialty facility, we've probably missed a lot of opportunities. We need to be reaching them while they're still in school. And I think we can partner and work with schools to do that. And we can partner with community hospitals that don't have access to behavioral health care. We can now do that to some extent using telepsychiatry. So for those of you who are in politics who helped pass a telehealth bill last year, this is actually very helpful because I can now, from the emergency room at Harborview or at the University Hospital, provide a telehealth consultation to anybody in any community hospital in the state when a person who's got a mental illness walks in their door. And they're one of those hospitals, they don't have a psychiatrist and they'll never have a psychiatrist because they're in a small rural community. But this stuff is portable. The good news with mental health is I don't actually have to touch you to try to do a good exam. I can do a lot with technology. So I think there are ways in which we can take the existing mental health specialists and we can try to leverage ourselves a little bit more effectively. So about 20 years ago, we already realized this problem. We were getting constantly sort of asked by people, how come you don't help us? How come we have no access to mental health? And we realized we just don't have enough specialists. So we said, where do the patients go? They go to their primary care doctors. So we developed this approach called collaborative care. And the notion there is the patient goes to see their primary care doctor. Could be a big urban clinic, could be a small rural clinic. And we said, what can we do to help that primary care provider be more effective in treating that person's mental health problems? So we add 2 people to the team. In these primary care offices where we do this work, we train somebody that we call a mental health care manager. That could be a licensed clinical social worker. It could be a nurse. It can be a medical assistant paired with a social worker. There are a number of ways to kind of get this job done, but it's somebody who's in the practice who says, my job here is to work alongside these doctors or nurse practitioners to take care of the patients who have mental health or substance abuse problems. So what we do with them is we train them in using some very structured ways of measuring how well a mental health problem is doing. We train them in some very good evidence-based brief treatments. So the doctors, what they typically do is they'll write a prescription for an antidepressant medication, for example. 30 million times a year, actually, somebody walks out of a primary care doctor's office with a prescription for a psychiatric medication. If you follow those people out a couple of years, only about 1 out of 5 really gets better. So if we have a person trained in the office who says, the doctor prescribed you this medication, I can work with you to try to make some changes. I'm going to give you some brief, effective counseling so that the pill by itself may not do the job, but if you can come here to the clinic and we meet 5 or 6 or 7 times, I can teach you some ways of making this pill be useful. We track all the patients that we have in this program in a computer-based registry tool. That's basically just a big list. And every one of these clinics where we do this work has a psychiatric consultant dedicated to it. So this is somebody who might work with us here in Seattle, and they're paired up with a primary care clinic in Ferry County, in Okanagan, anywhere in the state. And once a week they get on the phone together, the psychiatric consultant and the care manager. They look at this registry tool together and they say all the patients in this practice that are being treated for depression, for anxiety, for ADHD, whatever the problem is, I need to hear about every single one of them who's not doing well. And that psychiatrist then can make recommendations back to that primary care doctor about how to change treatment. Every once in a while, what turns out is it's a very complicated case. And it's the second or third time that we're talking about a patient, and we're really not quite sure what's going on. So there's a little tiny camera on top of this computer. This is Mark Avery, who's one of our psychiatrists. A little tiny camera, and Mark can say, can you put the person on the camera? So this is a clinic. As long as they have internet access, the nurse in the clinic can give the patient an iPad and say, now talk to the doctor at the university. And so I've already heard a bunch about this patient. I don't need to do a whole full-on 60-minute evaluation, but I have some very focused questions, and I can do a very good evaluation. And they can say at the end of that interaction, now can you get the doctor? They get the doctor in, and then there's the 4 of us, and we're together, and we can sort of say, this is what we would do next. Every once in a while, it's so complicated where we have to say, this isn't something we can treat in primary care. We really need to get the patient connected to specialty care. And that's a good thing, too. And then we continue to track them on this registry tool to make sure they don't fall through the cracks. So this is something we tested in a big study about 15 years ago in 8 states, in 5 states, sorry. 8 large healthcare organizations, and it turned out it was incredibly effective. It was a much better way to try to manage these patients who came to the primary care doctor than letting them struggle it on their own. We have since taken this approach from research and we've implemented it pretty widely. We have in our own academic healthcare system, this is a program we call the Behavioral Health Integration Program. This is the Puget Sound region. These are the UW neighborhood clinics. We have this program in every single one of our neighborhood clinics now. So any one of these 15 primary care clinics, you can walk in and the doctor can say, go down the hall with me, I'm going to introduce you to our mental health care manager. And if we need a psychiatrist to help advise us, we have that person. We talk to that person every day. If it's urgent, we can page that person right now. In 2014, the American Psychiatric Association gave us an award for this as a model program. And that was a really nice thing for me as a psychiatrist, because 15, 20 years ago, when we started to do this work, my colleagues in mental health hated this. Because they said, what are you doing? This is our, this is what we do, and you're selling it out to these primary care doctors. These people are going to come and eat our lunch. And I would say, I wish they could. You have no idea how much lunch there is. I really do. I mean, you saw the slides about how many people get no care at all, right? So we do this on a pretty large scale here, and we've also done, I'm not showing you all the data, good research on the economics of this. So when we did a very large study with 2,000 patients in 5 states, about 10 years ago, we found that people who were in this program had better health outcomes, they had better functioning, and in the long run, they actually had significant savings in total healthcare costs. So for every $1 that we spent on this program, we saw $6.50 in reduction in overall healthcare costs. And the biggest reductions were in inpatient medical. It had nothing to do with mental health. After that, it was pharmacy. After that, it was outpatient medical. And that's where we saw over 4 years some very big savings. And about 2 years ago, the Wall Street Journal ran a really nice article about this, saying you could actually just go to your primary care doctor's office, and if that office is well resourced with a program like this, you're going to get good care and you might actually have reductions in healthcare costs. So this got us actually more attention than anything that I've ever published in a major medical journal. So, so for those of you who are doing medical research, try to get your stuff published in the Wall Street Journal. Much more effective, not a surprise to this audience, but most of you don't read medical journals. We also had, starting in 2008, a really fabulous opportunity to partner with two partners. One of them is the Community Health Plan of Washington, and the other one is King County. This was the time when we had a program called the GAU program. Some of you may remember this was a program where the state paid for people who were unemployed and on short-term disability basic health care benefits. And at some point, they were having benefits for medical care, but not for mental health care. And the clinics that were taking care of these patients said, these are all people who have really high mental health needs. That benefit needs to include something that has to do with mental health. And they came to me and they said, you know, if we got a mental health benefits for this high-risk group of patients, what should it look like? And I said, don't make it a carve-out benefit. Because these are all people, like I showed you, they're all struggling these things. And make it a carve-in benefit, and let's see if we can scale up this kind of a program and put it into primary care clinics serving these high-risk patients. And so we have done that. We have now worked with over 150 clinics all through the state to serve clients in this program. We have now served over 50,000 clients, so we have a lot of data on how well that works. I'm going to show you a little bit of that data now. This was published a couple years ago in the American Journal of Public Health. And this is one way of looking at what we were doing. So the most common thing we treat is something called depression. So we took here about a couple thousand depressed patients, and we did something called a survival analysis. So what this graph shows you is the number of weeks here on the x-axis, and the y-axis is the proportion of patients whose depression is substantially improved. So this is response rate, basically. And so what we found is, as we were getting started with this program, we were following people in these clinics. If you wait long enough, about 75% of these patients' depression would actually improve. So that's the good news. But if you look at the time, it could take a long, long time. So we were not very happy with this, and CHBW was not very happy with this. And we said, gee, you've trained clinics in how to do this, but it seems to be taking a long, long time for these people to get better. In our research, it works much better than this. What can we do? So what we said is, what if we put 25% of the payment to the clinics at risk for trying to either get the patient better or making a change in treatment if patients are not yet improving? So we did that. We went back a year later. We looked at 6,000 clients. That's this red curve. Same clinics, same doctor, 6,000 new depressed patients. And what we found out is that the time it took to get half these people better shifted dramatically from 64 weeks all the way down to about 20 weeks. That's a huge reduction in time. And if you're struggling, and if your employment is hanging in the balance, if you're depressed for 64 weeks or 20 weeks, it makes a huge difference. We also did this here in King County. Those of you who live in King County, you are actually paying into a tax levy that funds this kind of program in about 14 community health clinics here in town, and we treat a group of patients called high-risk moms. These are both mothers and a few grandmothers who are parenting kids and who are low income, and we provide this kind of an integrated model of care for them. And we found the same thing there. So it took about a year to get half of these moms improved. We put this program in place, and now look what's happened. We shifted this curve, so where it takes for half these moms to get better, it goes from over a year to just over 8 weeks. So if you're a mom and you have a serious depression, this makes an enormous difference for you, for your family. And at the same time, we actually reduced healthcare costs, because remember we said we put 25% of the money at risk for doing the right thing, and not everybody was able to do the right thing. So this is a nice example of the triple aim. We got better health outcomes for less money. My thought about this is there is not a way that we can designate any one provider sector to try to do the right thing by mental health. We really need to share these tasks. We really need to collaborate. We spend a lot of money today on hospital care. You see all the stuff in the newspaper about Western State Hospital. Very, very challenging problem. We have a bed shortage. Here in King County, virtually every other county in the state doesn't have enough inpatient psychiatric beds. You saw that big slide early on where it said we're 48 out of 51. That is largely due to the fact that we don't have a lot of inpatient psychiatry beds in the state. That's what drives a lot of that ranking. But I don't think we should be spending all the money up here. We need to be shifting it down. So the next level would be specialty mental health care, our community mental health centers, other outpatient clinics. You know, with the Affordable Care Act, what's happening with our Medicaid expansion, what's happened is we have now a huge number of people who didn't used to have mental health benefits. They now all of a sudden have benefits for mental health care. But our community mental health delivery system is already at capacity. So now we got a lot of people who have benefits, but we're not well-resourced to figure out how to take care of them. This is where I think we need to say, what about primary care? Can we help support primary care practices with a systematic approach, kind of like what I showed you? What about primary care doctors on their own? What about school-based health centers? What about people who are living in the community? So the more we can sort of shift this stuff upstream, we don't wait until people are in juvenile justice or in the jail or in Western State Hospital. I think the better the chance we have in the long run to really make a difference with this. There are a couple of principles. I'm going to wrap up here on, in another slide or two. A couple of principles that I think are really important. There are a lot of people who've tried various ways of bringing mental health and primary care together. I think there are a couple things that if we keep them in mind, we'll get it right. The first one has to do with patient-centeredness. This has to be work where the mental health and the primary care providers really are working together. And the patient has to feel this. They have to feel like these people are talking to each other. They're all working with me. Ideally, we have the same chart, the same treatment plan. There shouldn't be a mental health treatment plan and a medical treatment plan. I'm the same person. And I showed you that example of that seriously depressed diabetic. That person needs one treatment plan. The second one is population-based care. To do this right, we need to be able to track everybody who's gotten started with treatment, because in mental health you have a huge dropout rate. People come in, a doctor writes a prescription for a medication, they go away. They're out of sight, out of mind. They're one of those 30 million people who walked out of a doctor's office with a prescription and then a month later there's not much going on. So I think that when we put people in this registry tool, what we do is we track them, and if they don't come back to the doctor, that care manager calls out to the patient. And it's a very powerful thing when a doctor's office calls a patient. That hardly ever happens, but it's very powerful. And the patients, they feel that. They'll say, wow, these people care enough about me to call me. So it's very important not to have people fall through the cracks. The third one is a concept called treatment to target. Just like any other health problem, mental health is something that can be measured. We haven't done that well historically, but we can measure things like how bad is the depression. It's a simple 9-item rating scale that I can give every one of you right now, and you can walk out here and say, how depressed am I today? We can measure how anxious you are. We can measure how hyperactive you are if you have ADHD. There are very simple tools to do that. And if we don't measure those things, we don't really know what we're doing in treatment. You know, mental health providers have said for many years, and we're all guilty of this, this is very difficult to understand work, it's secret, nobody can really know about it, you know, it's an art. I feel it's not so much an art, it needs to be something that we can all understand and measure. And I think when you make it something that you can measure, you can start managing it, right? Very, very important. So if anybody tells you that they can do mental health care for you, but they don't need to measure it, I would say don't buy. All right, the last one is we need to use treatments that are evidence-based. There's a lot of treatment. This is not just true in mental health. This is also true in the rest of healthcare. But there are a lot of treatments that you're buying from healthcare providers that are really not evidence-based. There is not evidence, even under the best of circumstances, that that treatment should get that person better. That's something we need to change. We need to be making sure that whatever treatment you're buying really have been shown by somebody that they actually make a difference. If we do these four things well, I think where we get is we get to what we're all trying to get to right now, which is something that has to do with accountability, accountable care, some place where we can see, are we really getting value? Is the patient getting value? Is the employer getting value? I think we can do that very, very well in mental health care. A couple more comments on where we are here in 2016, a little bit of policy context. I maybe should have started with this, but I'll put it here at the end. So we're well into Affordable Care Act and Medicaid expansion. And as I said, we now have up to 60 million Americans who used to not have good mental health coverage, or maybe had coverage but not good coverage, and actually have quite good coverage now. But now we have a challenge of having a delivery system that's not quite geared up to meet all those needs. Patients are still falling through the cracks in a big way. I think the fact that our own state and other state Medicaid programs are seriously working towards integrated care is huge. The other thing, I just came back from CMS. They will start in 2017. They have developed CPT billing codes for the kind of collaborative care, this evidence-based model of providing collaborative care that I just showed you. They were just approved. They're likely to go live in 2017. That's going to be really great for those of us who do this work, because this has been sort of a labor of love with a lot of research behind it, but people haven't had a good way to pay for it. So that's going to make a big change. I'm very excited about that. With accountable care, those of you, we're an accountable care network now. The University of Washington is. We have a contract with the state of Washington. We have a contract with Boeing to provide accountable care. And one of those things in those contracts are they're saying to us, when somebody has a depression, can you show me that you screened for it? More importantly, can you show me that the patient's gotten better? And if they're not getting better, we're not going to give you all your money. That's fabulous. I'm really happy that you're challenging us in that way, because that's the only thing that's going to make a large healthcare delivery system like us really change. So I'm very excited about that. The National Preventive Services Task Force has just come out with a recommendation that every person, including adolescents, including moms, and all adults should be screened for depression, because that's actually a very treatable problem. And you can see how much damage comes if you don't really pay attention to it. The NCQA is having new guidelines for patient-centered medical homes and for health plans. They will now start to have to report on depression screening and remission rates. That's something that is a good challenge to us as a field. What can you do as employers? So the first thing, and it's not on this slide, I think you can support Dorothy and Marianne and Nathan and all the people at Healthcare Authority in their quest to do what I showed you in this first slide, which is to really fully integrate the purchase and the delivery of mental health and medical services. I think it will make a huge difference. It takes a lot of courage. It's not easy work to do, because those things have been so separate for so long. And if we integrate the payment, it doesn't mean yet that the provider systems know how to play nice with each other. This notion of, you know, my internist and my psychiatrist should have the same treatment plan, that's easier said than done. But we got to do it. So I'm very excited about that. I think your purchasers, you should be demanding evidence-based collaborative care. You should say, I need to see if people are measuring the outcome. If we can't measure it, what am I buying? And that's actually quite possible to do today. I think you need to say, if you have a person who is in care but they're not getting better, are you changing things? Because just saying, I'm going to do one more session, I'm going to give the patient a couple more months of medication. If a person hasn't gotten better in treatment for a mental health problem in 6 to 8 weeks, we're probably doing something wrong. I wouldn't say let's make ourselves feel bad, but you need a second opinion. You need to make a change in treatment. If you say to that person, let's just do another 8 weeks of the same thing, it's not likely to make a difference. Same is true for hypertension. Same is true for diabetes. We need to treat that the same as we do with any health condition. And then finally, as we get opportunities, and as you all have opportunities to purchase healthcare, you know, I really think you should push for purchasing measurable, systematic, really fully integrated behavioral healthcare. If you'd like a little summary of this, a little bit more information about this, some of the research behind it, we recently worked with an organization founded by Patrick Kennedy called the Kennedy Forum. They put out a really nice brief for payers, for providers, on the concepts of integrated behavioral health care and on measurement-based care. Be happy to share that with you. You can get their briefs from thekennedyforum.org. If you'd like some local support, we have a program here at the university called the AIM Center. It stands for Advancing Integrated Mental Health Solution. We have a lot of stuff on our website about the work, about the research behind the work, but how we can help organizations that want to transform their practices in how to do that. And we're happy to help in any way that we can. So thank you very much. I hope I didn't go on for too long.
That was awesome. I think folks might have questions. So, you have a question? Susie?
What are the qualifications of a mental health care manager?
Yeah, it's really a function. It's not a profession. It's a set of tasks. So if you look at collaborative care, there is a primary care provider who says, I have a person here with depression, I'm going to start a medication. And then there's a couple of things that need to happen. Somebody has to track on that person so they don't fall through the cracks. Somebody has to be able to measure how well is that doing. Somebody has to be able to provide that brief counseling that the patient might need in addition to the medication. There has to be somebody in the practice who talks to that psychiatric consultant to make sure that we're making the right changes. That's a set of tasks that a whole bunch of different professionals can do. We've taught social workers how to do this. We've taught nurses how to do this, both nurses with and without prior mental health training. We have teams where they use a medical assistant and a psychologist together in a practice. The psychologist does the counseling, and medical assistant can do things like making sure people don't fall through the cracks, making sure that people are taking their medications. It's not so much a profession as it's a very important set of functions. And I think we can work with a practice and say, what do you have in place and what's the best way to try to make sure that that work actually gets done. I don't know if that makes any sense. All right, great. It's not something a PCP will do on their own because they're busy running from patient to patient, and they just can't do that stuff on their own. It's also not something a psychiatrist or a psychologist. If you refer me a patient, I'll take good care of that one patient. But I'm not going to remember all the other patients who are in the practice who are not getting well. So you really need a more systematic approach than just a doctor or a mental health professional. Yeah?
What do you see as the easiest quick wins, policy or otherwise, to get the state moved up the ranking to a little more respectable number?
I think I could turn that over to Dorothy. I think money is a big one. Right? Do you want to say anything about that, Dorothy?
Yeah, that is like the last place that we ever expect to be is between, well, I won't name the states, but those ones. But resources is just huge. And also I think that we're currently, and that's why the integration by 2020, we're administering the physical and behavioral health programs from at least 2 agencies and housing in a 3rd agency. So we're trying to get that all together. But fundamentally, it's all about the adequate resources. I think it's the #1 driver of those numbers.
And we can look at the resources we're spending now, because we are spending a lot of money on this, and we have to think about, does it make sense to have those resources go down 4 or 5 different channels, and in the end they don't add up to very much, or do we have to bring that together in some way and say, people have got to work together to use this money that we have? I don't think we maybe need a heck of a lot of new money. We need to spend money in a smart way, I think. Yes, all the way in the back there.
Thank you. Thinking about quality instead of just cost, are there any efforts underway to look at those PHQ-9s from a provider perspective and evaluate the effectiveness of the providers and the treatment that's being delivered?
It's a great suggestion. So I'm going to go back to my last slide. So NCQA is saying if you want to be certified as a patient-centered medical home, or starting in 2018, if you're a health plan, you need to report PHQ-9 screening rates and PHQ-9 remission rates, which is how many of the people who screened positive ultimately got better. And you can do that at an individual provider level, you can do that at a practice level, you can do that at a health plan level, and actually that's what we do. In this program that we're doing with CHBW, we have those ratings on every one of these clinics, and the clinics are financially at risk for some of these quality and outcome measures. And if they're not meeting these targets, they just get a lower payment. And I can tell you, that made a huge difference. This was a fascinating experience to me. So here, a couple thousand depressed patients treated by the same clinics. Now 25% of the money goes at risk for quality measures. And guess what happens? The same clinics start behaving very differently. When we started this work, they said, these are poor people, they're high risk, they're vulnerable populations. We're here in these federally qualified health center, we're doing God's work. There's no way you can try to push us on quality. It turns out, actually, a little bit of change in the money actually made a huge difference. We were pretty surprised about this big shift, and so we did some focus groups with people. And what we heard were the kinds of things that were not that surprising, but hugely important. So we said, what happened in your clinic? They said, well, the CFO never liked this program because it's one of those poorly financed public programs. We're not making a lot of money off of it. And now they're telling us that if we don't do this right, we're going to get even 25% less. We hate this thing. I said, what else happened? They said, well, they said to us, how come you can't make these targets? Are these targets reasonable? And they said, well, the targets are we're supposed to get people who are depressed better. There's nothing unreasonable about that. Well, why aren't you doing it? They said, well, because the care managers, they don't have access to the medical records. They don't have an office to work with. We don't have good communications with the doctor. So all this nuts and bolts stuff came up. And that's what happened. People worked out these little barriers that normally never get addressed. And guess what? The program became a lot more effective. So I think quality measures are very important in this area. And if you tie some money to it, actually can make a huge difference. Sorry, I guess I ran out of battery.
I can just. So you mentioned a couple of practice transformation activities to improve behavioral health care, and specifically you talked about co-locating primary and behavioral health care, and also you referenced telepsychiatry. I'm curious about your perspective on other practice transformation activities that hold promise to improve behavioral health care going forward, either from a clinical perspective or from your research. Thank you.
Yeah, I think I'd go back to this slide here. You could group those activities. So there are some very concrete things. So the notion that we have separate charting, separate care planning for people who have mental health or other kinds of problems, it's a huge barrier. And it's pretty simple with modern electronic health record tools to actually create shared charts. If you're still purchasing care where the mental health providers are charting in something that's invisible to the primary care providers, that's way out of date. That's people hiding behind sort of some kind of notion of doctor-patient confidentiality. I'm not saying that should be broadcast, worldwide, but your primary care doctor should know when your psychiatrist is changing your depression medications. We're all working together trying to take care of the patient. So that's a good example. This here, population-based care, everybody who started on treatment for a mental health or substance abuse problem ought to be tracked in some kind of tool by somebody. If they're not getting better, we're not going to spend a lot of time saying whose fault is it they're not getting well. We're going to say what else needs to happen. And sometimes you need to go to a higher level of care. Sometimes you're in a facility where you're not getting better. If there is no progress, we should get a second opinion and we should make a change in care. This notion of measuring, huge opportunity in mental health care. We're measuring A1Cs for diabetes. We're measuring blood pressures. We're not yet measuring routinely in mental health care. I think measurement is incredibly important. That's another practice transformation opportunity. Just to give a little example, I'm one of those people, I got high blood pressure very early on. I had high blood pressure in my late 20s. I've been taking a little pill since then, and I'm here talking. If I wasn't doing that, I'd probably have had a stroke by now. But the way that my doctor treated me for my high blood pressure, every time I went in, he said, it's still too high. Got to change your medication again. Got to switch to a new medication. At some point, we got to the right one. We were all good. The way we treat depression is you come and see me. I give you a medication. You come back a week later, and I say, how are you feeling now? You say, well, I'm a little bit better. And I'm a nice doctor. You're a nice patient. And so between us, we'll say, good. And I'll say, keep taking that pill. What if that doctor had treated my blood pressure that way? I'd be dead with a stroke now. So just to make that a little bit more concrete. So measurement, very, very important. And then finally, looking very hard at what are people actually buying when you're buying care. We still have too many treatments that are not evidence-based that are still being used. So those are just some concrete examples of, I think, where we could make transformation, would make changes pretty quickly.
So let's give them a round of applause.